Hi, everyone, and welcome to today's presentation. My name is Chloe Setsos, and I'm the project coordinator here at Capital Link, and I'd like to thank you all for joining us today. Today's webinar, entitled Focus on Behavioral Health, Cost Allocation Methodology for Value-Based Payment System, is the third webinar in a four-part webinar series offered through the Delta Center for a Thriving Safety Net. The full series, entitled Understanding Your Costs in an Evolving Payment Environment, has been developed by Capital Link and with input from JSI. And we'd like to thank JSI, the Robert Wood Johnson Foundation, and the Delta Center for supporting this effort. You can access recordings and PowerPoints from prior webinars in the series on the Capital Link website and Delta Center. Today's webinar will also be recorded and posted on the websites as well. This presentation will last about 50 minutes with 10 minutes for questions, but please feel free to ask your questions throughout the presentation in the chat box located in your GoToWebinar on the right-hand side. We would like to be able to answer any questions that you may have today. A PDF copy of today's slides are also available for download through the handout section of your GoToWebinar toolbar, as well as on our website as this presentation concludes. Today's speakers are Dave Kleiber, project consultant at Capital Link, and Bob Urquhart, consultant and retired FQHC, CFO, and David Whedon, CFO at Integral Care. And with that said, I'll turn it over to Dave to get started.
Thanks. Thanks, Chloe, and I'd like to echo your appreciation of Robert Wood Johnson Foundation and JSI and the Delta Center for supporting this presentation series. You know, you've probably, if you've been a loyal listener to this, and we have one more to go after this, you know, it's pretty much usually the Bob and Dave show. But today we have the Bob and Dave show. So we're really, really thrilled to have Dave Whedon on with us. And Dave, do you want to give us just a you know, the thumbnail sketch of your career?
Sure, just high level. I've been in the community mental health field for a little over 20 years, 16 of that at a rural center and 5 of it here in an urban one. I'm also currently serving as president of the National Association for Rural Mental Health, treasurer of National Association of County Behavioral Health and Developmental Disability Directors, and also chair of the Texas State Medicaid Managed Care Advisory Committee.
That is plenty. Wow, that's very impressive. So we really appreciate having Dave on to help us through this. Chloe, you want to move the slides, please? If you are a loyal listener, you know that we try really valiantly to get through all the slides within the hour and leave time for questions. So far, I think we're batting, as far as leaving time for questions, we're probably batting 0, 0, 0, Bob. I hate to say that, but we're going to keep giving it a shot. So we may move along quickly here. Just buckle up and stay with us, and we'll get through it. All right, so I guess this slide just talks about what we've done so far. So the first session was a very high-level cost allocation, talking about how to put your costs into buckets and how on a high level you might calculate your cost per visit and cost per patient, cost per client. The second session was mostly driven by Bob with his CFO background and how to get your internal systems set up so that you actually can calculate the data you want to calculate. And we'll get to some of that detail here in this session later on with some of the examples we have. But it's hopefully that the stage has been set now for us to talk a little bit, well, on some level more broadly about what value-based systems look like, and then more specifically about how we actually drill down to get those costs. Next slide, please. Okay, so obviously we kind of all need to agree to a degree on definitions. So, you know, what is an evolving payment environment? And I think it's safe to say that for most of us, it depends on where you sit. The definition that most people are thinking about is pretty much put together by the payers. And that just seems to be the way it is, right? But their costs, a payer's costs, are your revenues. For most of you anyway. I'm assuming most of our audience today is providers. And so it's really a different way of looking at the world. But keeping that in mind, we really require three things in order for us to get to what our definition of evolving payment environment and how we work with it. We have to be able to define and measure outcomes. We have to know how to accurately calculate the costs per client for whatever outcomes we are producing. So you have to identify those outcomes, then you have to say, what does it cost us to actually produce those outcomes, which means they need to be measurable. And then, of course, to stay in business, we need to get reimbursed enough to cover those costs. So I think the first two sessions we've done here are about setting the table for us to be able to do that accurate calculation of costs per client. And we haven't talked that much about outcomes and how we measure them and if we can measure them. So that's going to be kind of the challenge for us as we go forward. And I think we'll spend more on the reimbursement side. The last example today, I'll talk about it, but also next session, the fourth session in this series, we'll talk a little bit more about getting reimbursed. But that is the key. You need the costs in order to negotiate with your payers so that you can get reimbursed at the level you need to be reimbursed for. But you have to be able to come in with that detail. Next slide, please, Chloe. So this is kind of a visual presentation of where that evolution of costs or the payment environment has gone. We started at the bottom where most of you probably are now. PMPM for some, fee for service for others. And then there's a care coordination fee. If you get to the next level, you've got some little augmented payments. And then up above, you're talking about pay for performance and then some kind of possible shared savings. David, where would you say Integral has been, or where, how would you react to this chart as far as kind of the current state of things and where you see it going?
Yeah, so with this chart, this aligns pretty much a small summary of the alternate payment model framework that's on the HC LAN. And with that, here at Integral Care, we currently have 8 different value-based payment arrangements, and they basically run the whole gamut of this, from having one arrangement where we only receive payment once achieving measures to actually having shared savings and pay for performance on a number of them as well.
Wow. So do you have a PMPM to get paid under a per member per month system for much of what you do?
So here, most of ours, Texas is not an expansion state. So we still have a lot of folks that are under general revenue with the state. With the managed care organizations, most of it is based on fee for service with then some type of potential upside bonus based on performance. We do have some per member per month just on care coordination for some specialty health home people.
That's great. And for those who may not be familiar, the ACP-LAN stands for Healthcare Payment Learning and Action Network. So that is an organization that is focused on this evolution of the payment environment. And you can go to their website. There's a lot of good stuff on there if you're in policy or you just want to see where it might go. And obviously, as David mentioned, every state's going to be a little bit different in this world we live in at the moment. There's no generally accepted way that we're all in any particular box on this graph here. Next slide, please, Chloe. Okay, so this session we're going to go through 3 different aspects of this. We're talking about value-based payments. Well, what does that really mean? As we mentioned, it's a definitional issue about where, depending on your perspective. And it has something to do with outcomes, and it has something to do with dollars, right? That's the concept of value when we think about it. So the key is going to be, what does that formula look like, and how do we influence the numerator and the denominator of it? That's going to be where you can maybe have some control over things. So controlling those, or at least understanding those outcomes, producing them, could be on a standalone basis. As your own center, you could have outcomes that you can measure and you can achieve and you can demonstrate to your payers, or it might be that you're integrated with primary care through some kind of bidirectional system. So by bidirectional, we just mean that either you're doing primary care to some extent on your site, or you are providing your clinicians to a primary care provider on their site. And so that can work both ways. And in my experience as a board chair at a mental health agency for, well, being on the board for 10 plus years, a chair for 4, we tried both, and it was definitely a different amount of success. But that's one example from one county community health center. You're going to have your own situation, but you should know that there are a lot of different ways to get there. And the other thing we're going to explore today is developing care pathways as a way to organize your costs, organize your treatment methodologies so that you can identify costs in a more specific form for multiple patients who exhibit the same kind of symptoms. And at the bottom, then we're going to get to a time-driven. That's kind of the time-driven activity-based costing, which is a system set up and well established. We won't go into huge amounts of detail there, but you'll get a handle on where we're going with that idea when we're done, by the time you're done with this presentation. Okay, next slide, please, Chloe.
Just as she's advancing, just on the integration, it doesn't have to be an all or nothing. One of the health homes we have primarily concentrates on the care coordination piece. And through that, we were able to bring the well-check visits up from 25% of their clients to 71% of their clients, just because we knew where to find them and they weren't sure where to find them.
Wow. Well, along those lines, David, we've been talking to a lot of folks recently about telehealth. And one of the advantages they're talking about is that they're easier to find. Your no-show rate goes down because you're calling their cell phone and they always have their cell phone with them. Do you have any comment on that? Is that affecting things in your shop?
So it has brought down the no-show rate and helped with productivity some, but at the same time, we also need to learn more engagement practices for some of our client and our provider personalities on how to keep them engaged, to be sure it's a really meaningful contact as they're meeting with them on the phone.
And this could go on. We could have a session only on telehealth and COVID and all that's going on at the moment. But have you found that you've been able to kind of adapt your systems within those constraints in order to be able to kind of continue? I won't say business as usual. It's obviously not, but as far as your cash flow and your payments and your reimbursement, how are you guys doing along those lines in between in this new environment?
Right, and that's the challenge, is because a lot of the encounters are shorter in nature when you're doing them on straight telephone versus telehealth, and even versus face-to-face. So that changes some of your reimbursement patterns, and being sure to track your cost in comparison to that to know where you need to make some adjustments.
Yeah, that's very interesting, because you do have to look at what your costs might be. I mean, there's the technology aspects of those costs, which we won't get into here, but are pretty obvious. You gotta have either the video or just the telephone equipped. And I've talked to a few providers who actually provided headphones and with an integrated mic into them to their clients, because they couldn't afford them, and it just obviously there's no telehealth without that equipment. So but they found that they could get a payback on it, and they found there were some grant sources out there, as an aside, who were willing to front that because it was pretty much an obvious connection to their service delivery. So in this slide here, we're talking about, again, a little bit more about. Go ahead.
No, I was just going to say, one of the things we did too with a lot of the homeless population that we serve was got them basically burner phones that we could stay in touch with them without putting anybody at risk.
Interesting. So, wow, talk about technology. How many years ago was it that there was no such thing as a burner phone, right? A phone was an expensive thing, and now we're like, you have this what effectively is a throwaway phone, right? Isn't that what? It's incredible. Okay. So on this slide, we're talking again about the definition of value, and I think you'll all agree that especially in behavioral health, this can become difficult. It's not impossible. There are certain aspects of it where the outcome is measurable and identifiable, but it really can be more problematic with some of your clients who exhibit, certain more intense, serious mental illness, to be able to say, this is where we really want to get. If stability in a person's life is kind of what your ultimate goal is as a provider, what's the measure of stability, right? If they're not in jail, that's good. They're on social services and they're taking their medications, perhaps that's good. But you have to be able to make these measures to where you can actually take them to your payer and say, look what we've done, right? Because to some extent, you are trying to get in a value-based system. You're trying to get rewarded potentially for costs that didn't occur. That can be a challenge, right? When a cost do occur, when one of your clients goes to the emergency room or the inpatient psych ward, that's very clear. That happened. The costs are there. The hospital will be sure to bill you for them. And so you know what that financial impact is. But when you avoid that, how do you know you avoided it? How do you know what your interaction did was the key factor in avoiding that? So that's kind of where we really things get complicated. And here again, we talk about that equation at the bottom there is defined as not just your overall or your cost as an organization, but it's the health outcomes achieved per unit of cost expended over the entire care delivery value chain. Now that's a loaded statement right there. The entire care delivery value chain would suggest that includes all of the care inputs in a person's existence, in their life and in their challenge to stay as a stable member in society. So that's where I think it becomes difficult, and you add complications to this whole calculation. Next slide, please, Chloe. So again, how do we define those outcomes? Well, we obviously want to get those outcomes aligned with the treatment that you're doing and be measurable. And neither of those two is necessarily simple. And then we introduce this concept of, well, is an outcome how you define it, or is an outcome how your payer defines it, or is it an outcome how your client defines it? I think you can't escape having the client have some say in what a acceptable outcome is in their treatment. David, do you have any? Is this conundrum kind of strike home with you as far as being clear as to how to identify where you are in this? Whose outcomes we're talking about?
Yeah, so ideally where you're going to end up is the outcomes your payments will be driven on will be those that are important to the payer. However, in order to keep the individuals engaged, you've got to have a primary focus on the outcomes that are important to them in order to really even work on the other outcomes.
So without going into specific examples, I can imagine that there are issues, diagnoses, if you will, where that fits well and where it doesn't necessarily fit well, where there's, again, that identification problem. We'll get to a couple examples here in a little bit. So next slide, please, Chloe. All right. So again, this is, we're talking about when you try to measure outcomes, it's not volume related. That's most important, I think, is that we've come from a medical system as a whole, in the definition of a fee-for-service environment, is that you provide a service, you get paid, and so you are driven by volume, right? It's pretty obvious in your head. If I want to get paid more, I do more visits, and that's not necessarily where the outcome-oriented value-based systems are going. They want to get to a position where the outcome is good for the patient, good for the payer system as a whole, and it may not require that you see your client quite as often. So again, at the bottom, you can see that we talk about the equation's denominator referring to the total costs accrued for a particular to achieve a total outcome. The issue is going to be, in some cases, were you alone in providing that service? So were you in total control of all the levers that were the cost and all the costs involved in achieving a certain outcome, or were you cooperating with someone else? And if that's the case, how do you go about capturing those costs? That can get a little difficult. And David, I'm going to put you on the spot here. I don't think we talked about this, but is that do you guys provide primary care at all in your clinic locations, or do you, and if you don't, how do you control that whole, whose costs are whose challenge?
Yeah, so the way we have multiple models at the current moment, we have FQHCs on site at our clinics. We are on site at FQHC clinics, and then a bit of mix here and there throughout, some of it with just referral and coordination, like on that specialty health home where we got the kids into their pediatricians for their well checks. It ended up most of them had actually been assigned to a pediatrician that was in our parking lot. So we were able to basically escort them over to the pediatrician to get their well health check so that they could get that on record. But two, helping them understand the importance of that as we move forward. It's always an issue trying to identify who's has the primary responsibility for that intervention. So part of that is just on that upfront negotiation with the payers.
Which is just a necessary but a complicating factor, I can imagine. Okay, next slide, please, Chloe. All right, I threw this in here, and it has to do with the social determinants of health, partly because it adds some visual interest here. We get away from our text-heavy slides and give you a little picture. This is. I'm sure every one of you understands this concept. Whether you agree with which shaded part it should be bigger or smaller, or the percentages, as to all the factors that play into someone's health as a whole. The point of this is to point out that factors other than just your intervention as a healthcare provider have to, a person's health varies on that. Okay.
And just to remind folks,
back there for a second there, Claude.
Is on the behavioral health side of the house, we probably have more of that information on the social determinants of health than the payers or the primary care side of the house. And I know when we've looked at some expensive populations for some of the MCOs, we found that about 90 to 95% of those individuals were homeless individuals once we were able to track the data back to it.
Well, and that's really interesting because at the center where I was on the board of, it became obvious, this was in Washington State, and Washington State had a database that the providers had access to that pretty much said, here's what we're paying. This is what this particular individual is costing the state. And, there was this high flyer concept. They've got a whole bunch of names for them, hot spotters. You probably have something similar in Texas where they're just, that you can identify individuals who through their interactions with various social service agencies and government departments and different systems are really costing, you hear these statistics all the time about 20% costing, or 20% of the people costing 80% of the total cost. But those are all taking into account all those social factors you just mentioned, which are quite expensive. So I'll drop this into your heads when you're thinking about it. We, in this presentation, are talking a lot about integrating with primary care, but there are other ways in order to kind of get some of that piece of shared savings. But there are other ways to get there, right? You could work with your politicians, unfortunately, on some level, but also with the justice system. If you can keep people out of jail, it's the costs of daily, monthly, and annual incarceration time is pretty clear. I mean, those are talk about numbers that everyone can agree on. If you can have a say in preventing the state or the county, the city having to spend that money on an individual because of your input, then you should get a piece of that. That's really all we're talking about here. That may have nothing to do with primary care. It has directly to do with what your inputs are. So think about that. Don't just keep ourselves in this box of primary care. David, I'm going to put you on the spot again. Have you ever thought about that? Did any negotiations with people outside of the healthcare world in thinking about this shared savings concept?
Yeah, we've done that with the criminal justice system here, the city and the county, helping them understand where investing in some specialized programs or specialized services will be less expensive to them and get people to the most appropriate care instead of the costs that they've been having in the criminal justice system. And then also helping legislators understand the importance of investing in mental health as you look at what their costs are for individuals who parents may give up their custody rights because they just don't know what to do anymore. But if you can get some specialized programs out of there, then they don't become wards of the state, things of that nature.
Excellent. Yeah, I think we're just trying to get the message across that you need to think more broadly out there as far as where you can go, who your partners are, even on a payer perspective, right? Or in a way, what pots of money can you possibly draw from because you are having demonstrable impact on their world and their costs. Don't be shy about going after that. And as this slide talks about, there are quality measurement issues in some places and less so in others. If you can find those, the homeless issues or the ones that David just talked about there, where you can measure whether a person has interacted with the legal system, for instance, that's, if you can measure it, you can manage it, to reverse our little quote up above. And, that makes, I think, a lot to do with your ability to be able to convince those in particular control of the purse strings that you should have some piece of that. Again, it's a data collection and ability to demonstrate that you have a direct connection to outcomes. Okay, next slide, Chloe. All right, so measurements. What measurements are out there? And this is a combined slide. It talks about the 11 measures that the certified community behavioral health centers are working under. So I'm sure you're all familiar with CCBHCs, and if you're one, congratulations. And I know they're talking about expanding that to a couple more states, and there's been grants associated. I think this is and I'm going to ask you in a second, David, about your opinion on this, but my sense is this is coming. This evolution is going to happen. It's moving. There's a lot of momentum in this. But if you look at this level here, this is interesting to me. The ones in red are also HEDIS measures. So you're probably familiar with the HEDIS as a medical measurement system, and they are now actively developing a behavioral health set of measurements, some of which already exist in a sense. You can see these. So this isn't, you notice it's not what's your A1C level for a diabetic, let's say, something very clinical and lab related, something you could measure on a scale. Much of these are, assessments, suicide risk, follow-ups, readmissions. These are things that are a little more general. So, David, you're not, Texas is not a CCBHC state, but have you decided to, as a state, and I know you've kind of embarked on something similar to this, or kind of a prep as they waiting for the system to get to the point where Texas can become a CCBHC state, or do you want to talk a little bit about that whole movement and where you are in it and how you see these measures?
So Texas does not have the payment model of CCBHC at this point. However, the community centers have moved forward, and the state has in their strategic plan to continue certifying community centers as they meet the qualifications, with the plan over the next 2 years to get all the community centers certified. And at the same time, having discussions, we've had an 1115 waiver that has provided mental health services for both indigent and Medicaid individuals throughout the state for the last 9 years. It's going to be coming to an end in a year or two. And as that comes to an end, we're looking at the CCBHC model as a potential substitute funding model moving forward that would get us to some sustainable funding on the services for both rural and urban areas.
So tough question to ask, but so obviously you have aspirational goals to get there, right? I mean, you'd love to see this because getting that payment system set up would provide some stability, badly needed stability within the industry. would you agree that it looks like the momentum is carrying us there, or is that just wishful thinking on the part of the rest of the states who aren't part of this? The 8 states that were demonstration states.
So I believe the momentum's getting us there. I think the National Council's been working extremely hard on this from the federal level. The additional states that they had in the last CARES package, there may be some more coming out in some future care packages as we move forward. I think it will get there. It's just a matter of time.
Great. We'll all have our fingers crossed as we go forward, as it just seems like it's well overdue that behavioral health gets compensated in a fashion similar to how FKHCs have been, reimbursed since that system was created, and that I think it'll be a huge victory when everyone has that ability to work underneath that system. Next slide, please, Chloe. All right, so one other aspect, we won't spend a lot of time on this, but there's one other aspect that could impact your payment mechanisms going forward, and that is your client reported outcomes. I mean, when it's one thing if you can, as we mentioned before, if you can wave a lab report in front of a payer and say or a blood pressure report and say we're controlling this person's blood pressure, ergo, they belong in this group over here for which we get a shared savings program or payment, that's great. If you're in behavioral health and it's a little more difficult to identify those, as we've talked about, those outcomes, what does it really mean? Then the opinion of the patient means a lot more, right? How are you feeling, right? What do you do? How do you feel your care has been, and has it made an impact on your life and the stability of your life? So these assessments, which we talk about on this one, this consumer assessment of healthcare provider systems, that's a the CAPS system, but they are developing one for behavioral health. So don't go running out using that particular one, but I'm hoping that you have your own. Probably everyone, it has some kind of system for checking with their patients as to how they feel personally their care is doing. David, again, I'm putting you on this about all the time. Does Integral have a system for capturing this kind of patient-derived outcomes, period?
Yeah, so most of the behavioral health organizations that are credentialed either through JACO or another organization are collecting client satisfaction summary information at some level. I think it'll be important going forward because, again, the more satisfied clients are with services, the more they tend to be engaged in services moving forward, which will help with the outcomes, which will basically drive any alternate-based payment arrangement you have.
Yeah, it's going to be interesting to see how that connection ultimately occurs. Right, you're exactly spot on that their opinion makes a lot of difference. Right, you got to make, especially when it comes to patient. I had it on that slide there with the wheel there. They actually taking their meds, kind of following through on the treatment that you want. Their cooperation in their treatment is a huge part, and so that would probably be reflected in how happy they were. Right, if they're satisfied with their treatment, they're more likely to actually do what you ask them to do, and go along.
Right.
So next slide, please.
Which a lot of that gets back to person-directed planning and ensuring that the goals, overall goals in the individual's plan, are what they really want to work on too.
That's it. So there's an element in there, and they're agreeing that this is the course they want to take and the outcomes they want to try to achieve. And then it comes, we all work on data, and payers know more so than, or no less so than anybody else, probably more so. They're not in your shop, right? They're not there watching you have an interaction with a patient and say, oh, that was, look at I talked to this person and they're doing great, and it's because of your input, and you deserve payment for that. I mean, that isn't how the system works, right? It can't. It depends on what you put into your data systems and submit to them for payment, and that then runs into, what are your systems, electronic systems? What software do you have for electronic health records? And does it talk to, perhaps you mentioned the pediatrician that's in your parking lot. Hopefully before the call, you said it's 108 in Texas State. Hopefully they're not actually standing out in the parking lot. I'm envisioning that they've got an office out there. But anyway, if that pediatrician is an important part of your care with that particular client, do you have to this, not just you and your provider and their provider talk, but can the systems talk between each other? That interoperability, I think, is a big part, but it may be a challenge. You mentioned, David, that you work with a number of FQHCs. Does that your two systems talk? Is there an interface issue there, or what's been your experience?
Yeah, we actually have some shared access, but then again, ideally, if you can get everything into one system, you're better. But then also, too, as you're talking about alternate-based payments, start negotiating up front with whoever you're working with on information they may have that you don't, so you get it on a regular basis and know where you stand.
There you go. Okay, next slide, Chloe. All right, we're almost to the point where we can introduce Bob back into this conversation, but one thing we are going to talk about here is to try to get your costs into buckets. We mentioned that at the front end of the call here, so that you're doing these care pathways. We're going to run through this really pretty quickly so that we can stay on time here, but there are certain treatment systems. Here's two of them: assertive community treatment, which we'll talk more about in the next session, by the way. We'll break that down a little bit and try to cost an assertive community treatment protocol. But there's also first episode psychosis as a group of patients who fall into a somewhat standardized method or methodology of treatment. And because of that, it lends itself to being costs that can be assigned to those treatment and what you do in these particular programs that is common across a number of different patients. And therefore, it's easier from a costing perspective to be able to go to a payer and say, we have this group of X number that fall into this group. Here's what we do for them. Universally. Now, granted, there's going to be some difference between client to client, but generally this is our protocol for treating with them. And these are our costs. And here's what you're reimbursing us now for. And that's your basis for negotiating as you go forward. Next slide, Chloe. Okay, so this is again we're talking about the bidirectional behavioral health integration and how important it is that in fact you do think about this in two different ways, and it doesn't. I don't know. I'm going to go out on a limb and say it doesn't really necessarily matter which direction you go with this. You do end up with different individuals having input on one individual, one client's care. It could be case manager, in which case you need the case manager needs to be interacting with both the senior medical health professional, that's the mental health professional that's working with that client, as well as their PCP, excuse me, and patient education on some kind of maybe interacting with your pharmacy or the pharmacy you normally deal with, and you've got to have that interaction. What's their dosage? How are they doing? And as far as reordering goes, are they looking like they're actually taking the medication you want them to take? And then care coordination goes both ways. And I'm probably a little bit behind on this, but to ask you just real quickly on your thoughts on this. This example come up with depression. Is this common that you have your providers chatting with the PCPs back and forth about any particular client's issues?
Yeah, the providers chat back and forth. Also do consultations on issues that may come up where somebody may just need some advice on some potential medication changes, where somebody may not need the full behavioral health range of services, but the primary care physician just may want to check on what they think might work best for the individual.
And this is, you can see, I mean, how difficult that might be from a costing perspective if there is this shared between organizations, between parts of an organization, that kind of where are the costs. The outcomes or this treatment methodology is obviously good for the patient, but it may be difficult for you to be costing. But that's part of this challenge, right? Is in that whole
So we're staying lost.
Okay. Yeah, Chloe, is there? Can you move the slide forward? I'm sure you're trying over there. Okay, so quickly, we're going to be utilizing we'll be talking about that. I think the idea, the next slide is going to probably give us a little better look at this, but it effectively is what we just talked about: replicable, measurable workflow steps. That's what you what the sort of the general definition of a care pathway. And so you're multiple aspects of a client's life come into this. The social, the medical, and the behavioral all come into that idea. Let's move on to the next slide, Chloe, because we can talk a little bit. You can see this visually. This is a slide I borrowed from a National Council presentation, and I appreciate that, by one of their consultants. Now, it may be a little bit difficult to read because of the coloring and everything else, but you can get a sense here of, over here you got screening and assessment came up with a particular set of conditions for this particular individual, and then all the actions that could be started to try to deal with those various issues, and what level of service they're at, the service bundle you might put them in, and then how long each of those services can take. So I'm not going to go into a lot of detail here. This is a great idea, but it does give you some sense of how complicated this can be. So hopefully you didn't get out of this that we think that using care pathways and doing, drilling down and doing your costs is going to be easy. It's important from a payer negotiation point of view that you have these costs in hand. And Bob in a minute is about to go into how you can kind of start building those costs. And you could use this this table right here to identify where some of those costs might lie in the buckets they're in and start costing those buckets. But it is important to do. It just is not necessarily going to be easy. Next slide, please, Chloe. Okay. So Bob, I'm going to let you, everyone's probably been wondering what, I haven't heard from Bob on this one yet. So got him to do these next 6 or 8 slides on kind of the methodology of doing this costing. Thanks for your patience, Bob.
No problem. Thanks, everyone. So I'm going to take you through some pretty basic stuff, and I'm sure that it's nothing really new here, but the key to this is making sure that, as it says on the first point here, that you can capture your actual cost for your client care. It's not about charges billed or collected. It's about what did you actually spend in terms of provider costs, the support staff costs, any kind of other folks involved in the process, or other equipment. I think a little earlier we talked about giving phones out, things like that. You want to capture all the costs that you had to develop this client care, and to the detail level, because you're going to need that as you go forward. Everything you want to do is around the client, and you're not going to necessarily, attach the cost to each individual client, because you need a staff of 1,000. But the way you set up your general ledger and set up your chart of accounts will help you get to that cost by the client. You want to make sure that you do have the full cycle of the care for the client. I want to specify one thing. We talked a little bit about our cost versus the cost to someone else and another organization providing cost. We need to focus on our cost. What is it costing us to deliver our piece of the care? We have to also rely on the fact that the other organizations we're working with are doing the same thing. So that when it gets to the payer is the one that's going to take this total cost of care concept and say, okay, client A cost our system $50,000. It's broken up by this much was done by the behavioral health, and this was done with primary care, and this much was done other places. We want to make sure we have our actual costs as accurate as we get them. And I keep saying our costs and accurate. You want to get direct costs. You want to try to stay away from allocations and estimates. Try to get as much direct costs as you can. And it's going to depend upon the actual use of resources. Who are you using? The personnel you're using. Where are you doing? And what's the cost of that room that you're seeing the client in? Any unique supplies to that care? When you get into the time devoted and capacity costs and support costs, the time devoted and measuring that, and capacity cost and measuring that, they can be simple at a high level, or you can drill down if your systems are capable. And that's where I think that whatever your time capture system is, you can get it down to the time devoted to each client, that's great. But I think that the ultimate, the worst case is you have a total of all the time you spent, and you can divide that by the number of clients you saw. You can get a reasonable estimate. So what you're trying to get at is reasonable, and Dave flavor is when I say this, but you don't want to let perfect get in the way of very good. I mean, there are a lot of ways to get this without going crazy about it. Next slide, Chloe, please. So the way to kind of build this is having an understanding of your historic average cost per client and measuring that on a regular basis, and what is that on an overall basis. Now you want to look at clients by the intensity of needs. So you're going to start to get subsets of your client base and break them into groups and determine what the intensity of the care for each group needs to be. And then to Dave's earlier slide, talking about the pathways for that group that needs intense care. What do they need? What does that pathway look like? What are the things we need to provide to deliver care for that particular group? And then identify the unique cost to those services. So you start out with your average, what it costs you for most clients, stratify them by the intensity of the needs, look at what's in that group, and then add on to your base, what are the unique costs to this particular pathway that you've developed. Next slide, Chloe. So the 7 steps, I mean, I'll try to go through quickly for you. Selecting the condition you want to cost out and look at what those chronic conditions are that are best addressed in a coordinated way, broadly define them, and be able to know what those issues are. Second would be defining the care delivery value chain. What's the clinical pathway? What does this involve? Go back to the chart a few slides ago. What are the steps involved in determining what we need to do for those clients? And then how do we capture and measure costs for each step along the way? That would be taking that pathway and identifying clearly who's providing the service, where is it being provided, what other things we use besides people to get this result. Each step of the process, being able to identify the costs associated with it. And then include all the relevant resources. Make sure that you have everybody that's involved in delivering the care to the clients on that particular day, that particular session, that particular interaction. Next slide, please, folks. Step 4, obtaining timeliness streak process. I mean, there are ways to get there. You can do estimates by looking at what other people have done, and there's a lot of stuff out there you can find to determine what an average would be based on a collection of maybe some groups in your state or some other groups that you work with, and that can be good for general stuff. You want to try to get to actual times and as detailed as you can though for the real interventions and the real care pathways, because that's where you're going to determine what it's truly costing you on a client basis. Next slide, please. All right, so this is kind of a flashback for those of you who've been with us on other sessions. We try to break the cost into component costs. So provider cost, the cost of the psychiatrist, psychologist, the nurse, the behavioral health nurse practitioner, whoever is providing the care, the direct care, that's the provider cost. And it's the salary, and it's the fringe benefits, and what is the cost of that resource. Direct support cost, everybody else who's involved in delivering the care to that client on that particular interaction. Is it an LCSW? Is it a nurse? Is it someone else in the organization that's involved in that interaction or that visit or meeting with the client? Capturing all of that and capturing the salaries, the fringe benefits, and all the other costs. This would be where the burner phones go in. This would be where if you bought headsets for folks. This would be where if you provided laptops, whether they be community laptops or common area laptops, that kind of stuff would go in there. Enabling costs is kind of a catch-all, and that'll mean different things to different people. David Weeden might have some direct on that, but enabling costs would be you want to get a client from your place to pediatrician, and they took a cab there, or they got a ride there. So providing transportation. maybe providing a meal for them while they're there, maybe providing meal support for them when they're home. What kind of assistance do you give the client to enable them to achieve the outcomes you want them to achieve? And then overhead costs would be the cost of all the other people in your organization around involved in direct patient care, finance, patient accounts, facilities, all the folks that run your organization, that support everything you do to be able to do the client care. This is a formula that is right from a NAC bulletin that we developed, and I think you'll find that it's kind of universal. It doesn't matter what your industry is. Change provided to buyer cost, and you have a retail calculator. So this is kind of just a way to put things in a grouping so you can understand where your costs are. So when someone says if the cost per client is $5,000, you can look at it and say, well, where is it? Where is it? Is that too high? Is it too low? And specifically, where is it? And there are benchmarks, general benchmarks for each one of these that you can look at and say, well, okay, I'm off here. And why am I different than the benchmark? Next slide, please, Coach. So this says estimated capacity of each resource. This is a calculation to say what everybody involved in this process, what is their capacity to deliver the service or deliver the care that client needs in that particular time, and what is the practical capacity for that period of time. And as it says here, grouping procedures into common resource pools and develop CCRs for that pool is probably the most direct and I won't say easy, but the most direct, understandable way to get there. Next slide, Cody. And then I think when you've gone through all of those steps, and I want to flash back to our previous session on building your systems, this is all driven by the fact that you've developed your general ledger, your chart of accounts, your electronic health record, your practice management system. All of that's capturing all of this information at that detail level. So you can summarize the cost of all those activities and develop what that overall cost would look like. And then, as David said a couple of times, this is the tool you have to measure yourself against other organizations, other benchmarks, and also to sit down with your payers and say, look, here's everything we're doing. Here's what our delivery method is. Here's what our cost of care is. And we need to have that plus some other factor for us to be a viable organization and make reinvestment in our people and be here for the long haul. So this is the kind of the anchor number that starts the conversation. And I'd just say a quick story. Dave Cleaver and I were talking to a payer, and one of the questions I asked was, how many times has a provider come into you who was able to lay out the actual cost of care for any given activity, or any given set of clients, or any given base, to say this is what it costs me, I'll start on negotiations there. And the payer's answer was never. So what that really means is that we are putting the payers in the driving seat. They're going to tell us what they're going to pay us, because that's what they want to pay us. And then we go back and try to fit our care into that. We got to flip that around and say, we're going to do all of this to come up with what that cost of care really is, and you're going to have to pay us for that care. So I think that's kind of the starting point of turning negotiation around so that we're driving negotiation versus the payer telling us what they'll give us. That makes sense? Okay.
Yeah. Next slide, please, Chloe.
Dave, I think it's back to you.
All right. So we're going to finish up the presentation here with an example, and this is just a made-up example. It happens to do with a mentally ill client who also has diabetes, and of course, depression is a common comorbidity with diabetes, and so you may find yourself with quite a few patients who fall into this particular group. We've set up three scenarios. One is which it's just a fee-for-service medical care only scenario, so you just got that side of the shop is seeing them. And then we talk. There's another scenario just where we're costing on a PM basis what they're getting, along with a care coordinator involved, and interaction with the behavioral health side. And then the third one is that basically same scenario, except now you're involved in a value-based program. So whereas one case you're doing the work, but there's no system set up for you to basically get that additional payment. The third system gets you there. Now, again, we're making this stuff up. I'll be totally straightforward with you on that, but it follows through. And I think, David, would be interesting to see how you think about this in your context. The value-based system at the bottom there, you can see we came up with is, and this is not unusual. If they set a threshold at which you need a certain number of patients in this group need to, have these certain outcomes. And if 50% of them do, then there's no payment either way. And this is an shared risk and upside and downside. So it's a shared risk payments scheme. So below that, you are owing $250 per patient for every percentage of those patients under 50%. And over 50%, you get $1,000 for everyone because you're saving them so much. Next slide, please, Claude. So you put together your capacity cost analysis, and that's what we did. Bob was just talking a little bit. Here's all the variety of people that might be involved. Now, not all of them are going to be involved in this care. This is just to give you a list and kind of breaking down, getting into the detail we talked about where you can break these, how many vacation weeks they get, CME. You're really trying to come down to a cost per minute, cost per visit, to be able to, if you really want to get there, right? If we're going to get to the end goal of this system. The key here is your daily availability adjustment. You'll see there in the middle. It's how often, what other things besides direct client care are these people involved in that draw them away from direct client care? So think through those analysis when you put those in. Next slide, please, Chloe. This next is just a continuation of that same table. So if you saw it on an Excel spreadsheet, it'd all be one long table. The key here is, all right, now you're developing your scenarios and you're putting in the time that you see the individual practitioners participating in that care treatment, in that pathway. And then all that's doing is, over on the left in the blue column, if you've got a psychiatrist spending 15 minutes with somebody and the therapist spending 20, with one of these patients when they're in and have seen their PCP and then they come over to see you, you can see how that then calculates into a cost over on the right. And on those three kind of purplish shaded columns give you some sense of what those costs are. Now the fee-for-service side is low, right? This is not a fee-for-service, no behavioral health involved, but arguably from the client's perspective, this is not full care, right? Their treatment, their depression is not being treated. So this is, while the medical side might see this as they're doing their part. If this client is not getting the full set of available treatments for their behavioral health issues, their depression, then you're not treating them. You're not getting the outcomes you want. So the other two scenarios involve those people as well. Next slide, please, Chloe. All right, so it's a bit of a complicated slide, but you can kind of see what's developed. The first three columns there are for fee-for-service, and then the second scenarios and the third scenarios involve getting reimbursed. The fee-for-service and the PPM are roughly the same in our system, and you've also got a PMPM payment for your behavioral health interaction. On top of that, you're given a grant for your care coordination. That's not the best of all worlds, but that's common for how care coordination gets paid for. So you run all that down and you can see that you have much higher costs with scenario 2 and 3, and so all of them are basically at break even. But the key to this are two. At the very bottom, you'll see what our estimates were, and again, I'm making these numbers up, but they're probably not too far off of how the world actually works in your world. What are the actual costs to the entire system of this group of patients? So you're looking at $750,000 is what an untreated diabetic costs, a group of diabetics costs when they have to go into the hospital. When they're not, all their symptoms are not being treated, they cost the system a lot more. And so you now have, you add this care coordination aspect. They're getting more of their systems, more of their treatment is done and more of their symptoms are being treated. But the costs come down, but still overall the system is losing a lot of money on these patients. And then that's the reason that they're driven to create these value-based payment mechanisms. Now, you may not directly have, though it would be great if you did, had some input on how those are structured. But in this case, you can look over to the side on the value-based payment one, and you can see that, if you were at 50%, you're just break even. It's pretty much what it looks like in the center. But if you are able to increase, improve the outcomes to the extent that you're actually saving the system substantial amount of money, you can go from having what amounts to a break even treatment protocol to making some decent money. Now, granted, this is just an example of how the system might work, but you can see the magic of it, if you will. You need to get in early in order to be able to negotiate with your payers so that you can accomplish this system. You can work under it, and you can actually generate those results that you're after. Next slide, please, Chloe. This is our last slide. I realize we've run out of time here. And once again, we did not make it to this last one. We didn't make it to the questions, but I'm not sure. Chloe, do we have any questions? I don't think we do. I don't see any.
Actually, sorry.
So,
we don't have any questions right now, but if, again,
go ahead.
Any questions, please feel free to ask your question in the GoToWebinar toolbar on the right-hand side.
Great. And so next time we are going to, we talked about a few times what we're going to be talking about in the next.
I was just going to say that
what we're going to be talking about in the next section. So this is to just give you some session. Sorry? Say again, Bob?
That's okay. Yeah, I guess all I wanted to say is about the Chloe's comment that if you don't have a question right now, you think of one later, by all means, email any one of us. Our contact information is available. We've committed that we'll answer any and all questions, whether they're asked during the session or after the session. We're very happy to do that and provide you with information you need.
Thank you. That's right. So the next slide, please, Chloe. The last slide gives you some contact information. Feel free to download the whole presentation. You can get all this information and contact any of us directly if you have specific questions. We appreciate your attendance today and hope you'll join us for the last of these sessions in 2 weeks' time. And thank you very much. And Dave Whedon, thank you very much for sitting in with us. That was really great input you provided today.
Not a problem.
Thank you.
Thank you, everybody. And you will be directed to a very brief survey, and any feedback we